All right, well, it's 8:02, so we would like to go ahead and get started, be respectful of everyone's time. I'd like to thank you all for joining us tonight and welcome you to the IODA Journal Club for Disparities in Healthcare, where we are going to be discussing 3 articles, and we'll get into the details of what those articles are shortly. Before we get into that, I just wanted to briefly give a little bit of information about IODA for those of you who are unfamiliar or maybe unfamiliar. So IODA stands for the International Orthopaedic Diversity Alliance, and this is a worldwide collaboration with a vision to unite leaders in orthopedic surgery and industry to promote diversity, equity, and inclusion throughout the world. The aim is to provide a global forum to promote diversity in orthopedics through wide engagement, development of resources, support of diversity efforts and research. Membership is free and open to everyone in the healthcare sector. So if you're joining us tonight and you're not already a member, we welcome you to join. And there's lots of fantastic resources that you can find on the IODA website. The IODA does have a board that consists of 12 members, including 6 regional representatives, encompassing the entire world. So there's an African representative, Asian Pacific representative, European representative, Latin American, Middle East, and North American representative. And it's also supported by 5 committees that progress the core activities. So again, if you're interested, we welcome you to join. Again, it's free. You can go to orthopaedicdiversity.org and join to be a member, as well as access all the other fantastic resources that are provided by IODA. My name is Holly Pilson, and I am an associate professor of orthopedic trauma at Wake Forest University School of Medicine, which is in Winston-Salem, North Carolina. I am also the IODA North American Regional Representative and the chair of the Diversity Advisory Board. We are excited to have with us tonight as our featured guest, Dr. Boris Zelle, who's a professor of orthopedic surgery, also specializing in trauma at UT San Antonio. Dr. Zelle is the vice chair of research and the chief of orthopedic trauma at UT San Antonio, where he regularly treats an underserved population who face challenges of limited access to healthcare, language barriers, food insecurity, malnutrition, and mistrust in the medical system. He's a previous member of the AAOS Diversity Advisory Board and an active participant in numerous diversity initiatives, including disadvantaged high school and college students, including the Texas statewide Joint Admission Medical Program, as well as institutional programs at UT Health San Antonio, like Pathways into Medicine and Doc Talks. Over the years, Dr. Zelle has served as a mentor to numerous students, residents, and fellows with diverse backgrounds. Within the orthopedic department at his institution, he created a 1-year orthopedic research fellowship consistently filled by minority students, including those who are women, Hispanic, and foreign nationals. This research experience has been instrumental in guiding students into orthopedic residency training at prestigious institutions. Dr. Zelle also engages in various initiatives aimed at addressing healthcare disparities in vulnerable patient populations. In addition to his local contributions, he has been prolific in publishing more than 100 peer-reviewed articles. He has presented his research at regional, national, and international conferences and has delivered lectures on healthcare disparities and culturally competent care at esteemed national and international organizations. So thank you, Dr. Zelle, for joining us as the lead author of the 3 articles we're going to be discussing tonight.
Thank you very much, and I appreciate the opportunity. And again, thank you for having me with you.
Yes. In addition to Dr. Zelle, we're joined by 3 resident presenters tonight that we'd like to also thank for their time. And Dr. Lutnick is a PGY4 at the University of Buffalo, who is also a member of the Diversity Advisory Board and will be presenting one of our articles tonight. Dr. Bullock is a PGY4 at UT San Antonio. It was also a co-author on the article that he will be presenting tonight. And Dr. Vo is PGY5, also at UT San Antonio, also a co-author for the article that she will be presenting tonight. And so these are the three articles that we are going to be covering. We're going to start out with Dr. Bullock presenting on fate of the uninsured ankle fracture, significant delays in treatment result in an increased risk of surgical site infection. And I'm going to turn over the slide control to you, and you should have it now.
All right, thank you so much. Let's see if I can get this to work. All right, as Dr. Pilson said, I'm Dr. Bullock. I'm one of the PGY4s in San Antonio. And thank you for having me this evening and allowing me to participate. And I would be remiss if I did not sing Dr. Zelle's praises for just 1 second. So I was also one of the research fellows and have been working with Dr. Zelle since I was a third-year med student. And I think I can speak for all the residents when I say that he's been a great mentor and has advanced our research department tremendously. And the city of San Antonio especially is better to have him with us. So thank you.
Thank you.
So again, this is our paper. It was published in the Journal of Orthopaedic Trauma in March of 2021. A little bit of background of what spurred this paper on. So we know that from previous literature that insurance status has been influential in the elective orthopedic practice, whether that's arthroplasty or our sports colleagues, where they've shown that patients that are underinsured tend to have worse clinical outcomes and surgical complications postoperatively. However, not a lot of data was available at the time of our publication regarding orthopedic trauma patients. And in particular, if you take a look at that x-ray, this is a patient I actually recently took care of just like 2 months ago. This is pretty typical for San Antonio, where you have a laborer that presents 2 to 3 days after a work injury to our hospital after he had been to one of these satellite emergency departments where they placed him or malreduced him in a splint, and he finally makes it to our care. So anecdotally, we see a lot of these cases, which ultimately led us to start thinking about why these patients are presenting to us at that time in this condition. And the ankle fractures themselves kind of serve as a good litmus test because they're a time-sensitive injury, but they're yet not emergent, where a patient would present emergently to a hospital and seeking care, but yet initial stabilization is still important. So our study question was basically, does insurance status with these patients influence the time to presentation to initial orthopedic care, the time to surgical management, and then postoperative follow, and then does it have any influence on surgical site complications postoperatively? So in regards to the study design, this is a level 3 retrospective study. It was conducted at our level 1 trauma center and county facility. It's actually a catch-all. It's like 22,000 square miles. It serves 2 million people and abuts up into northern Mexico and even eastern New Mexico. And we queried CPT codes for all closed ankle fractures occurring from 2014 to 2016. Our inclusion criteria were 18-year-olds or older or adults, isolated, unstable, closed ankle fractures that required surgical management. And our exclusion criteria were any open fractures, any ankle fractures involving the plafond, and then those patients that had polytraumatic injuries. In terms of our results, if we look at the demographic data, we queried 619 fractures, with 489 were actually included in the study. And there was almost a 2-to-1 ratio of uninsured patients to insured. And interestingly enough, our insured patients actually had a higher incidence of hypertension, diabetes, and increased ASA score. They were older and they were more likely to be female. In terms of our uninsured patients, there's significantly more tobacco use and were more likely to be male. In terms of our outcomes assessing access to care, our uninsured patients 52% of the time presented to an outside hospital, compared with 38% of the insured population. Our uninsured patients presented 4.5 days versus 2.3 days compared to insured patients. And then uninsured patients underwent actual operative treatment at 9.4 days compared to 7.3 days in the insured cohort. And in terms of follow-up, if we set a cutoff at 3 months, 40% of our uninsured patients were lost to follow-up at that time compared to 20% in the insured patient population. In terms of surgical site infections as defined by the CDC definition, we had a rate of 11%, with most of those being superficial. And then whenever we did stepwise logistic regression modeling, we found that as there was an increase in delay to treatment, we saw an increase association with surgical site infections. So what are the strengths of the study? I think it's clearly defined patient population, inclusion and exclusion criteria, and clearly defined outcomes and questions. It deals with a unique vulnerable patient population that was of a relatively large sample size. And I believe our statistical analysis was robust and comprehensive. Some of the weaknesses for the study, I think, would be the inherent flaws with the retrospective study. And there was also bias in the loss to follow-up, where a lot of our patients were lost at 3 months. And as such, we don't know if those patients went on to develop surgical site infections. And then also there's a geographic bias in our study, which may make it not generalizable to other indigent populations throughout the country. And then also it would have been nice to know the reasons for delay and why our patients were lost to follow-up. So what are the critical contributions that I think this makes to the literature? I think this expands on the previous findings that we discussed earlier in the elective orthopedic surgical data, and that we expand that now to the trauma patients. I also think it broadens the data regarding timing to fixation, and it adds a little bit of a nuance when you consider socioeconomic status and how that influences time to surgery. And obviously, I think it also raises some important ethical questions, whether that be, should all these ankle fractures be being initially evaluated and stabilized by an orthopedic surgeon? And then is the current referral system failing our uninsured patients? So I think in conclusion, I think our study shows that delays in surgical treatment may increase the risk of surgical site infections. And then at least in our underinsured patient population, they experience delays in initial presentation, surgical management, and are more likely to be lost to follow-up in the early perioperative period. And some of the questions I had for our more senior participants tonight would be, what are your strategies to streamline and reduce delays in care for these urgent or semi-urgent orthopedic trauma cases? Do you think the study has any implications to other orthopedic traumas, such as like distal radius or calcaneus, maybe proximal humerus? And then what is your approach regarding these injuries in terms of your surgical timing? And then do you even consider insurance status whenever you're treating these patients?
Yeah, thank you, Dr. Bullock. I think these are fantastic questions. I can weigh in certainly to start us off. So I think you raise a lot of good issues here about streamlining and referrals. So I don't have any fantastic ideas, but I will say I did definitely think about that when I read the paper and wondered what we can be doing to better inform our referring hospitals, especially in the emergency department, whether it be providing education or some flow chart that would allow them to better sort of get patients who have unstable ankle fractures or any unstable fracture that needs surgical management that may not be available at their hospital, to sort of get plugged in sooner with someone else at a center like yours or mine who would take care of it. I'd say it kind of is a little bit of a catch-22, right? Because a lot of times what happens is at some of those community hospitals, there are community surgeons who are very capable to manage ankle fractures, but don't really have robust systems in place to always manage the uninsured population through their health system or how their practice is set up. And so I think you also have to consider that as well. The other thing I was thinking about is, what role potentially telehealth could play, especially some of our communities that are very rural, and it may take a while for them to get into the larger cities, and see someone who could surgically manage their fracture. But if there was some way to streamline care at that first touch point so that we could get patients better plugged in and at least offer them an earlier visit, that might be a better way. I don't know if you guys have used this to change any of your practice in San Antonio, or how you've used this data
Yeah.
to streamline.
Yeah. First of all, Shane, very nice job. And it is a little bit of study that has been coming directly out of our practice or based on observations that we have here on a daily basis. We are a university hospital, but at the same time, we are also a county facility. And it's just such a common scenario that we've seen that we're seeing as of today, that patients have an ankle fracture, they get seen at an outside facility, at a private hospital, where they get splinted and they get sent on their way and advised, call your orthopedic surgeon tomorrow morning. But then they don't get access to that care because they cannot make the payment upfront. And at that time, it's not that necessarily they realize, okay, we have to come to the county hospital. It frequently then results in a delay of a week or two, where patients are trying to figure out where things are, and where it's sometimes also deceiving when we say that's a semi-elective surgery, because that's what our study shows, that it is a problem if they stay in their splint, if they redislocate in their splint, and that it is not a benign injury. And it also points out a little bit that we know that access to healthcare for elective surgeries is different in certain in vulnerable patient populations and certain minority groups who have less access to joint replacements, but that we're actually seeing similar things in orthopedic trauma as well, where else the perception is somebody has an acute injury, insured or uninsured, gets taken care of the same way. Here we see that there are actually significant barriers that these patients are facing, based on their zip code and based on their insurance status. But yeah, it's a difficult problem to address, and also talking to colleagues and from other centers, they encounter similar issues, and they just say, as a safety net hospital, our doors are open anyways. Open your doors widely, so make it known in the community that that if patients don't get that access to surgical treatment for their ankle fracture, that they present where they will be taken care of. But yeah, it's a difficult message to reinforce publicly.
Yeah, I think it's a good point. I think, one of the reasons that I enjoy doing trauma is because I don't ever, to the third question on this list, I don't ever look at a patient's insurance status. It doesn't influence my practice at all. My patients have operative fractures, and really the only thing that's going to change that is if they're too swollen for surgery. And I know not everyone has that practice model, and not everyone works in a county hospital system or university hospital system where they have sort of the support, the financial support to be able to absorb that. But I think that that is something to consider your practice setup.
Yeah.
Well, thank you so much, Dr. Bullock. We're going to transition to our next article, and I'm going to turn over to Dr. Lutnick. Let's see if I can turn the slide control over to you. All right.
Thank you so much. Let me make sure that this is gonna. Oh, I see it. Okay. My name's Ellen Lutnick. I'm a PGY3, actually. I got a promotion. Thank you, Dr. Pilson, at the University of Buffalo, but I'm presenting on lack of diversity in orthopedic clinical trials conducted in the United States. Just make sure it's okay. Perfect. So this is a study that was published out of JBJS in 2014 with an impact factor of 5.3, and affiliations were at Texas San Antonio and then McMaster University. I thought this was a really interesting article reading through. So the goal of this article was basically to determine the percentage of orthopedic randomized control trials in the US that included race and ethnicity data. And I didn't realize how much of an issue this was until I read this article and kind of read some of the stats and really kind of obviously described the disparity in reporting in our literature. So there's been several orthopedic studies previously that have suggested that patient race and ethnicity obviously are important predictors of patient functional outcomes. And these kind of titles that are pasted around the text on this slide are just examples, especially in most recent years, with kind of the civil rights movement being back in the highlight since 2020 and the Black Lives Matter movement. There's been a lot of studies, I think mostly specifically to total joint arthroplasty and utilization of total joint arthroplasty and access to care in orthopedic elective surgeries, describing these issues. And the NIH in this study talked a little bit about the NIH mandating that clinical trials that receive federal funding provide an analysis of results according to race and ethnicity. So the goal of the study was basically to look at all of the randomized controlled trials in the US and record also the racial and ethnic distribution of the patients enrolled in those trials. So as far as the methods, this study included all major orthopedic journals and 5 major medical journals from January of 2008 to December of 2011, and included a manual search of all randomized controlled trials published through these 32 orthopedic scientific journals. Inclusion status was based on the randomized controlled trial design, performance of the study within the field of orthopedics, and then performance of the study within the United States, and went on further to specify that multi-center trials were included if the primary study location was within the US, or if at least 80% of the included patients were from the US. Any inclusion of demographic race or ethnicity data was considered to be a report of such data, whether or not the results were actually stratified based on racial or ethnic groups. And then univariate comparisons were performed for all the extracted study variables to determine whether or not there was a significant difference between the studies that reported race or ethnicity data and those that did not. And then there was a further multivariate regression model that was performed to determine whether or not there was independent predictors of reporting based on race or ethnicity. And so for results, there were 158 trials with over 37,000 patients that were performed in the US during the study time period. Only 32 of those trials, or about 20%, actually reported anything related to race or ethnicity. And again, this is not necessarily stratifying results based on race or ethnicity, just reporting on it. And then within those patients that were included and enrolled in the studies, 4.6% of patients were self-reported as Hispanic, and then 6.2% of patients were reported as African American. There was this multivariate regression, which the table from the study is here, of the 4 variables that were looked at in the multivariate regression, including whether or not the study was a pain study, if there was any government funding, the sample size, and the journal impact factor. Only government funding was identified as a predictor of race or ethnicity reporting, which makes some sense based on the fact that the NIH does have that caveat to funding, but unfortunately there wasn't really anything else that seemed to encourage these trials to include that level of data. So the implications for the study, I think much like other literature focused on DEI and barriers to care, this study serves to advocate largely. Primarily this shows that our patient population is not accurately represented in our highest level of research in orthopedics. But I do think that there is something encouraging, which is that prioritization of the study investigator or the sponsor can result in more representation of more minority patients and can potentially result in more reporting on that data. I thought the discussion also did a really nice job of highlighting some of the limitations, including with respect to possible randomized controlled trials that might be missed because they were published in a different journal. The fact that the overall poor reporting of race or ethnicity across all randomized controlled trials led to an inability to determine the exact proportion of enrolled minority patients. And then also the fact that randomized controlled trials only represent a small portion of orthopedic literature. It is our highest level of evidence, but doesn't take into account retrospective or other forms of analyses. And so in conclusion, this is, in the discussion as well, was highlighted as likely a multifactorial problem, including patient-related factors, including cultural barriers, language barriers, potential, medical mistrust, concerns about risk, time commitments, any other more standard barriers to care, including transportation, reading level, family and work responsibilities. The list is relatively exhaustive in the discussion, but I think it does a really nice job of highlighting all of the possible factors that might go into why this might be a problem. And in conclusion, basically describes that there are a few randomized control trials performed in the US that have any reported data on race or ethnicity, and then potentially even more importantly than that, that enrollment of these minority patients in those that do report this data is substantially lower than the representation in the US population, which limits the generalizability of the study conclusions. So there is definitely, as kind of a final takeaway, I think an important role to be played both by the investigator to remove any possible barriers to participation and hopefully identify those barriers within their own patient population, and then for sponsors to hopefully require reporting and recruitment efforts of minority patients within the studies that they're funding. So for a few questions that I came up with after reading this article, for those investigators who have participated themselves in randomized controlled trials, whether or not it's within their own center or multi-center, from the list of things that are highlighted in the discussion, what is your personal experience with recruiting minority patients, and what have you found to be more effective, or what barriers to participation have you witnessed, and how have you approached that? And then secondly, with the uptick in research related to disparities in patient care in recent years in orthopedics, what effect have you seen, if any, from this research in your own clinical practice? And then I was thinking more on the practices of your colleagues, because we're all in this room having this conversation, part of this journal club, and obviously aware of this as being an issue. But maybe in colleagues that maybe are not as actively a part of these conversations, how has that contributed to the level of conversation surrounding advocacy on the topic?
Yeah, thank you very much. Nice job. And yeah, comment from our side. I mean, that was a study that we published a number of years ago. And it was also a little bit an eye-opener when we looked at the number of minority patients who were in these trials, that across all trials, and again, that's the best evidence that we have, essentially, where we have to assume these are the studies that we are utilizing to guide our treatment, all trials, the level 1, level 2 evidence-based studies. And that within those studies, only 4% of patients were, where it was reported, were Hispanic, whereas the actual Hispanic representation in the US population is 4 times higher, with 16%. Or also with Black patients, 6% of patients included in that trial. In trials in the US, only 6% are Black, whereas in the actual population, the representation is 12%. That we can really get from this, that trials that are getting published in orthopedics are not actually representing the US population. And with that, how much value can we give to the body of the orthopedic literature if the patients enrolled in these trials is not representing the patients that we treat? And on the investigator side, being part of trials where we are enrolling, it is challenging. And certainly when you enroll patients into trial, you can't select in a way, hey, for this trial, I want to enroll more minorities. You want to enroll anybody who's willing to enroll, but you certainly want to open up your trial as much as you can in the way that you, for instance, have Spanish translations for the consent, that those are not exclusion criteria, which is probably a big one. And where you offer opportunities, for instance, that you also have outcome measures that are translated into Spanish. Yeah, it doesn't help if you have, if you design a trial with, for example, a patient-reported outcome measure that is only available in English. Well, that in itself will already close a trial for enrollment of Hispanic patients. So I think those are a little bit the things that you have to look out for as an investigator. With multi-center trials, also include centers that will give you a diverse population. Yeah? If all patients are recruited from geographic areas or from centers where you can expect a fairly similar representation, where you can expect a representation of minorities that is not reflecting the minority representation in the US population, you have to look out for centers that may give you that spread. Yeah. So those are things that I think should be part of the planning phase. If you want to represent the actual US population, you have to see where are you recruiting, and also what are potential barriers for recruiting patients.
Yeah, I think I agree with those factors. And in addition to that, I would add that you mentioned, ensuring that your consent forms and all of your documentation for your study are translated in other languages. And I would say also it's important to look at the health literacy level of the consent forms and the information regarding the study, because most of the time the information that we have on procedures and consents especially are really not designed at the health literacy level of most lay persons that have no experience in healthcare in the country, and that's regardless of race or ethnicity. One of the things I think it's helpful in addition to that is our site has participated in several multi-center randomized controlled trials through the metric group, is to have a patient stakeholder on your board. I think that's been significantly helpful, especially the more diverse patient stakeholders you have. They can help you anticipate what potential barriers that you might have in reaching certain populations. For example, most marginalized populations that have a large mistrust of the medical system are probably not going to agree to sign up for a randomized trial where the risk or the stake is high for them. If you tell them, we know that this one, or we anticipate this treatment is going to work better, but there's this other treatment that we're trying to compare it to, and there's a significant risk, the mistrust won't really allow them to participate. And so you have to make the risk low to ensure that the trust is there, that they're going to get still great, excellent care, and still be able to participate in the research study. But yeah, I agree with all of the other comments as well that were made by Dr. Zelle.
Yeah. And the study also prompted other investigations that we did. For example, it was followed by designing a foot and ankle questionnaire, not designing, but just taking the AAOS foot and ankle questionnaire, and not only translate it into Spanish, you also have to do a cross-cultural adaptation. You have to do a forward translation, a backward translation. You have to, as you just mentioned, make sure these questionnaires are written on a literacy level that is inclusive. You want to look at a 5th or 7th grader level that questionnaires need to be provided. And yeah, it's a lot of work validating an English questionnaire, or a questionnaire that was originally published in English in the Spanish language, because you have to not do a one-on-one translation. It will not give you the correct result. With a Harris hip score, if you ask a patient, can you walk a block? Well, the Hispanic patient may say, what's a block? I can walk 100 meters, but what do you mean with a block? Yeah, that's an example.
Yeah, fantastic. Good job. So I'm going to turn it over to Dr. Vo now, who's going to share her screen and round us out with the final article regarding health disparities in patients with musculoskeletal injuries and food insecurity.
Okay, let's see if this works. Can everybody see that?
Yes.
Yes.
Perfect. Okay. As Dr. Pilson said, I'm presenting on the food insecurity paper that I worked on with Dr. Zelle, and just to echo everything that Shane mentioned earlier, I have really enjoyed working with Dr. Zelle on getting this paper published, and have been very grateful for all of his assistance and guidance through this process. We were able to get this paper published in Core And there's a journal impact factor of 4.3 for this paper, for this journal. Basically, the study objectives of this paper were to determine the percentage of patients who experience food insecurity in an orthopedic trauma clinic at a level 1 trauma center. We wanted to identify demographic and clinical factors associated with food insecurity and identify whether there are any differences in some outcomes that patients experience, specifically complications and reoperations. So several studies have demonstrated that nutrition and malnutrition specifically is associated with poor outcomes in orthopedic trauma patients. And so this kind of association triggered us looking more into this in depth. And other studies have also shown that food insecurity is prevalent in orthopedic trauma patients, even more so than the general population. So putting these two concepts together, we came up with the idea for this paper. And what we did was a chart review of data from one of the orthopedic trauma clinics at our level 1 trauma center. We used the hunger vital sign as the screening tool for food insecurity. So of note, this is just a standard screening that all of our patients in our clinic undergo. That's done as part of clinical practice and not necessarily part of the study. Just really quickly, the USDA defines food insecurity as a household level economic and social condition of limited or uncertain access to adequate food. We used the Hunger Vital Sign, which is this 2-question, fairly straightforward survey that all patients completed, and any response of either sometimes true or often true to either of those 2 questions screened positive for food insecurity. And this has been a validated method for screening for food insecurity with up to 93% sensitivity and up to 95% specificity, depending on which question they answer positively. So then, once we applied our inclusion-exclusion criteria, basically we looked between November 2022 and February 2023, and we excluded any multiple records, which were just patients who followed up. And then we just excluded any patients who did not complete the questionnaire, found 121 patients who were eligible for the study, excluded any patients who were treated non-operatively or had some kind of non-fracture related care, such as an infection or things like that, or were not treated primarily at our institution. That led to 63 patients who screened positive for food insecurity negative, and then 37 who screened positive. Our outcomes were defined as deep infections, superficial infections, reoperations, and non-unions. We did adjust for covariates listed here that are generally accepted covariates in this field of research, and then we did our statistical testing. So what did we find? 37% of our patients screened positive for food insecurity, which if you do look at the general population, it's about 14%. And then in the data that we found specific to orthopedic trauma patients, the highest we were able to find in the literature is 25%. So ours was significantly higher than even the published numbers for orthopedic trauma patients. The other things we found were that patients who screened positive for food insecurity were significantly more likely to have either no insurance or insurance that was Medicaid. The other interesting thing that we found were patients who screened positive for food insecurity were more likely to be employed. And just as a note from our data, most of our patients were laborers or construction workers. The other thing to note was the BMI, the average BMI in the patients who screened positive for food insecurity was significantly higher. This has been published in the literature for other types of patient populations, so that correlates to that. Outcomes, what did we find? So patients who screened positive for food insecurity were at increased risk of all-cause complications, risk ratio of 1.89, and also significantly higher superficial infection rates. Our, as you can see from this chart, our numbers for deep and infections and non-unions were pretty low. So it was really hard for us, even if there was any kind of significance, it was hard for this study to be powered highly enough to capture any of that. So kind of going into that, limitations of this study is we had a relatively low sample size, which made our study a little bit prone to statistical fragility and lacking enough power to maybe find some other differences. Of course, it's a retrospective chart review, so it is prone to misclassification bias. And then there is some response bias inherent in the food insecurity screening tool, but we do feel like we implemented a validated screening tool and that we would be able to capture those patients appropriately. The other thing is our patient population comes from quite a variety of patients on the US-Mexico border. We also have a lot of hill country and surrounding rural areas. And so we tend to have a lot more laborers and construction workers and ranchers, which may not necessarily be generalizable to other areas of the United States. Overall conclusions, food insecurity is very common in the orthopedic trauma population. And we feel that with this 2-questionnaire screening tool, it's relatively feasible to do in clinic. And it helps identify patients who are at risk for food insecurity and subsequently who may be at risk for postoperative complications. I think implications for the future, there's been studies that have shown interventions addressing food insecurity have positive outcomes on patients. And some of those examples of things that other institutions have done are food delivery, meal plans, food vouchers, which is what we ended up doing as part of our clinical practice for our patients, and some nutritional food cooking classes. So I guess my biggest question for the faculty are, how do you see this, I guess, playing a part in your patient population and how your care could be affected by food insecurity? I think kind of just a follow-up to all of this, one of the things Dr. Pilson mentioned earlier was health literacy. And I think that plays also a factor into a lot of this as well, because patients, while they are food insecure, we could guide them on, you know, here's a food bank or here's this or that classes and things like that. But I think a lot of it has to do with their health literacy and understanding the system and where to go for all these things. So anyway, I'm just curious to see how you think this would play into your practice.
Yeah, fantastic job. I mean, I think this is a very big issue, and a couple things, couple thoughts I had. I think one of the most, as a surgeon, as a physician, or anyone in the healthcare field, you know, we've done a better job, especially in recent years, of really capturing several of the social determinants of health in our patient populations. Most of us have Epic or some other electronic medical record system that helps us better capture these things and kind of know more about the social aspects of our patients' health. What I would say is the more crippling side is that many of us are not well equipped by our health systems and in our by our social workers and things like that to really know how to resource patients. To your point, like I bet most of my partners, if someone screened positive in their clinic for food insecurity, wouldn't really know what to tell the patient, like how to help them. And so I think that in many ways it keeps many clinicians from asking or wanting to know, because you feel bad if you can't really help someone with that information, right? And so I think really it's important, and it sounds like, you know, I want to applaud you guys for the job that you did. And I even highlighted in your article that what you actually did do when someone screened positive for food insecurities, that you resource them with information as well as food vouchers. And so I think that is half the battle, right? Is figuring out what to do with this positive screening. And so I think, while it's important to know the information, I think you have to do the work on the front end of saying, like, what are we gonna do when we have this positive information? What resources do we have to provide patients when they screen positive? So I do think it's a significant issue. The other thing that I think that we all recognize that the study highlighted was, you mentioned that there was a statistically significant more employed population in the was it the uninsured? I can't remember exactly what it was.
Right.
The
So
food
in
insecure.
the
Food
yes,
insecure.
ma'am.
And so I think that just really highlights the big disconnect behind what is a living wage in our country, and how many of our patients who are laborers who work hard do not make a living wage to be able to provide for themselves and their family. So I think that just really highlights that big disconnect in our country. Anything to add to that, Boris?
Yeah, since well, again, fantastic job on that paper and also on the presentation tonight. You know how I think about it, it's I think nutritional optimization, if there was one thing that I could change for all of my patients, it would be nutritional optimization. I think many of our patients are malnourished. We have data for that. We see that 1 out of 4 patients does not know where the next meal is coming from, which is a shocking number. But I do think that nutritional optimization for these high-risk surgeries that we are performing on many of these patients is just so crucial. And it's even more important. Other things that also come out of it, we're also talking long-term optimization of health, if we can get our patients to get access to appropriate nutrition. So yeah, I think it's tremendously important, not only for orthopedics, but we are talking about any disease that we see in our society. I think diabetes, peripheral vascular disease, heart disease, they all have a common denominator that where nutrition plays into it. The big challenges, and Holly, you mentioned that, is why asking if you can't address it, and yeah, I think it's the reality that a lot of us live in. Why asking patients about stress disorders if we don't have access to getting them into the psychiatry clinic? And similar with food insecurity, what we've tried here is to give them referral sources to food banks, to outdoor kitchens, to churches, and started them on a food voucher. But it's also going back to the same problem that you mentioned earlier, the literacy. We don't have good data on that because we don't have good follow-up on those patients, how they utilized it. But when we started, we noticed that the food vouchers that we handed out, that they frequently were not utilized. And then we started, how are they utilizing the other resources? And again, it is meaningless to them if you connect them with a state-based food stamp program and they have to call a 1-800 number. That may not necessarily work for them. So yeah, we are still learning, and we have to continue looking for nutritional interventions that work for our patients.
This is a tag-on question to kind of the current conversation, but I know that there's some description in the literature now related to a social work presence in orthopedic trauma clinics. I think mostly described with like intimate partner violence and with like PTSD and mental health. But this seems like it would be a really good outlet for having, I mean, and again, part of the argument for multidisciplinary care, especially with orthopedic trauma, because it is such a vulnerable population. Do you have any experience at your center? I know it sounds like you have some ways that you've connected patients with resources, but is that something that you're working towards or something that you envision as being feasible?
Yeah, I'm past working towards it based on some of this data. That was something that we tried for the orthopedic trauma clinics, that we would get a social worker, but we understaffed. It was denied. And yeah, my experience is, not
Yeah,
positive on that. But yeah, sorry, Holly.
no, it's okay. I was gonna say, similarly, I think we do, I try to advocate for even a patient navigator, which I think would be fantastic. Doesn't have to be a social worker, right? It just needs to be someone who has knowledge of community resources and can help patients navigate the system. And not just with food insecurity. I mean, just physically navigating our healthcare facilities is a challenge for many of our patients. Transportation to our healthcare facilities is a challenge for many of our patients. So I think that can be, a fantastic addition to our trauma clinics and our trauma practices, is to have someone that can sort of be an extension of ourselves and help, not just screen, but also equip and resource patients with the things that they need, and really help improve patient care. But yeah, I think that's hopefully to come.
Yeah.
Yeah.
Yeah, and any one of us has probably been in the situation that you've helped a friend to navigate the healthcare system, to get an appointment, or to get somebody into the right clinic where they needed to be, and how difficult it is for us as healthcare workers to help a friend just going through that. Imagine how difficult it is for somebody who does not understand the healthcare system at all, who has language barriers, and who may be underinsured. So for me, it's a struggle to get a friend into the right clinic within a decent amount of time, and imagine how much harder it is for somebody who doesn't have the head start.
Yeah.
I wanted to open it up in case any of the participants have questions. You can feel free to put your question in the chat, or we do also have a Q&A function that you can use as well. Any other questions or comments from the panelists on any of the articles?
Just a comment. Thank you so much for sharing. It was really great to hear both of your perspectives about performing the research, and just, sitting with so many people who actually were a part of the projects too is always a treat. So thanks. Yeah, I agree. I echo that. I really appreciate you all being with us, and it's really special to hear from especially the sort of the backstory of why you decided to even start the study to begin with, the sort of what the clinical questions were that prompted you to look into this further. So I don't see any questions coming through in the chat, and none in the Q&A. So I think that's going to be a wrap for us tonight. I really appreciate all of your time, all the fantastic work and research that you're doing to highlight the health disparities that are existing in your community and also in our country. Keep up the good work, and best of luck to all of you residents finishing up residency and pursuing fellowship. And thanks to all of you who joined us, and especially to you, Dr. Zelle, for all the incredible work that you're doing and the mentorship that you're providing.
All right. Thank you very much. Again, I feel honored and privileged that I could be here. And also thank you to you for putting all of this together. And thank you to the presenters who all did a fantastic job presenting those papers.
All right. Have a good evening, guys.
Thank you.
Bye-bye.
Have a good night.
Thank you.
Bye-bye.